Health inequality is a growing challenge when it comes to primary care and general practice, and basically every aspect of health in its totality. Well, in this episode, we're reviewing a document created by HealthWatch England that looks at some of the challenges that exist when it comes to health inequalities and their recommendations that they have to try and change that as we try and tech enhance your primary care and learning. Shall we crack on? GP learners, welcome to this episode where we're going to be looking at the HealthWatch recent documentation and information that they've provided about tackling health inequalities for our population. Have you had a look at it, Andy?
Yeah, so this is interesting. So this came up in what might be a few weeks ago for some of those people watching, but for us it was just a few moments ago. There was a breaking story in Pulse which said that HealthWatch are recommending that GP practices prescribe over-the-counter medicines for vulnerable groups and people at socioeconomic disadvantage. And we were observing when we were talking about that this runs contrary to what we have been, as GP practice, asked to do for many years, which is avoid prescribing medications that patients can just walk into a pharmacy or often a supermarket and buy off the shelves because it had been deemed that that wasn't the best use of system resources for people to have to sit through what might be a 10-minute GP consultation at quite a high cost to the system to be prescribed, 16p's worth of paracetamol. As an extreme example, there are other things which have a cost closer to that of a prescription. And the reason that people might choose to do that, because that sounds quite inconvenient rather than just walking in and buying them with your own money, is that some people are at such a level of socioeconomic disadvantage that they would rather do that, or are only able to do that, rather than actually pay the full cost of the medicine if they went into the pharmacy or the supermarket, because by going to a health professional they would get that on prescription, which, because of their socioeconomic status or other status, would mean they got that for free from the pharmacy. So it was interesting. So it kind of caused a few waves seeing that story. So, and that was in response to this report from HealthWatch. So we thought that we would have a closer look at the report.
And just to be
here
clear,
we
this
are.
is a recommendation. This is not policy. So for those people, just to make that clarity, in terms of, obviously we cover a lot of things that are either plans, recommendations, policies and stuff. This is a recommendation. This is not a policy currently. It may be, we don't know, but time will tell. But definitely, let's have a look at the report itself. It's relatively short compared to some of the more standard things that we look at from, I guess, things like NHS England and stuff. It's basically a web page and a PowerPoint. But talk us through that first paragraph there, Andy.
Yeah, so basically, they're acknowledging that they have heard as HealthWatch, so they are the patient advocacy group within the country and within the NHS. And they have obviously noticed that and heard from patients that the cost of living crisis is having an effect on how they choose or can access various healthcare services. And it's not just about general practice and prescriptions in this report. So they have done a survey which has reached 2,000, or contains the responses from 2,000 adults in England. And they've actually asked them sort of 4 times over the course of between October 2022 and March 2023. And then they have published these results recently, asking about a number of things, from going to the dentist to how they buy and access medication and access to GP appointment, how they travel to NHS appointments. So it's an interesting study, actually. I think it's good to maybe next look at the some of the data that they presented in their slide pack, and then maybe come to their conclusions. So just as we do that, let's get this in full view for everybody. There we go. Hopefully people can see that really nicely on the screen now. So again, they're talking about why they've done the study, on what they're focusing on, talking about how and when they asked people. So yeah, let's dive in and look at some of these graphs. What they've done here, so just to understand the graph, is they have asked people a number of sort of difficult, questions about difficult choices that they might have had to make about their healthcare, here represented by each mini graph. And then it's broken down by all. So dark blue is the average population, those on means tested benefits are represented by the pink, and those on disability benefits are represented by the green. And that's, I have avoided taking up one or more NHS prescriptions because of the cost. So, and it's higher for these groups in receipt of benefits. I have avoided attending an NHS appointment because I couldn't afford to travel to the appointment. 17% of people on disability benefits have given HealthWatch that response, which is a lot, actually. That's surprising to me. I've avoided buying over-the-counter medication I normally rely on. That's quite high, and I do think this might be where they're drawing that recommendation that they're from their data from about GP practices should provide this medication to patients on prescription. I've avoided booking an NHS appointment because I couldn't afford the associated costs. So that's just the point. The cost of the telephone call, for example. And interestingly, that is much higher in these populations receiving benefits. 6% for the general population and 17% for disability benefits, 20% for means tested benefits. And then the other noteworthy response they got was, I have avoided going to the dentist because of the cost of checkups and treatment. And that's actually the highest thing that people have been avoiding. 22% disability benefits, 20% mean tested benefits, 15% of the general population actually avoiding going to the dentist because of the cost, which is a big issue, and is talked about a lot.
I think the interesting thing with that one as well, Andy, it's not only the highest for all of them, it's double for the average population individual. So 15%, the next closest one is 7%, which is the I've avoided buying medications over the counter and stuff. So, that's clearly an issue for many of the population in terms of accessing dental healthcare and stuff.
Absolutely.
Yeah.
So this graph was a little bit difficult to understand, and actually the table I think is better. So it asks essentially those questions, and it breaks it down by the average for the whole sample, those on benefits, and then also breaks it down by age categories. And actually we see that it's actually younger people who are making these, or are choosing to make, or are forced to make these difficult choices compared to older people. And that might say something about how people prioritize their health in the different areas, as well as their means to support their health, and also perhaps how busy they are, because money is a cost to accessing healthcare, but so is time, because it can take time to engage with the systems to get appointments, particularly GP appointments, I'm sure we would admit at the moment. So that's really interesting. Anything jump out at you from these statistics, Gandhi?
No, like you said, Andy, there's definitely a variation across the age. I guess financial status has an impact. So obviously the people on disabilities, they seem to have a more challenging journey there. But also those with means tested are similarly quite high compared to the average population as well. So it does show that socioeconomic status has an impact in these kind of variables and stuff, doesn't it?
It certainly does. So, and that it's a very short PowerPoint presentation. For completeness sake, they're just saying, all of the questions that they've asked, not just those that they've chosen to focus on within the graphs. So that's just there for completeness sake. And there's some details about how to contact them about it. And I'm sure we'll have the link in the show notes below. So, really interesting report. If we just go back to the web page, we can see what conclusions they drew from the report, and then their recommendations. And then I guess at the end, we can both speak to that recommendation, which was to general practice about prescribing to vulnerable people, providing prescriptions for over-the-counter medicines. So they highlight that the financial burden is really weighing heavily on those choices in particular groups. Just like we picked out from the data, really, they're talking about people on disability benefits, means tested benefits, and particularly younger people aged 18 to 24, increasingly making those difficult choices. And they've picked out those areas which basically had the highest response for making difficult choices. So people on disability benefits particularly twice as likely to have avoided their usual over-the-counter medication than the general population, 15 compared to 7%. 1 in 5, 20% of people on means tested benefits have avoided booking an NHS appointment because of the associated cost. And that's not they asked about transport separately. That's like the cost of the telephone call or the access, or the cost of accessing the service. And then they're highlighting that young people, 18 to 24, twice as likely to avoid an NHS appointment due to travel costs. Interestingly, younger people much less likely to drive these days compared to older population and compared to that age category previously. So they're increasingly reliant on public transport and taxis, I guess. And then just on average, 1 in 5 people from each group avoided the dentist because of the related cost. And it was 15%, if we recall, for the general population, which was pretty high, really. And then they talk about the tangible actions. So they set out immediate tangible actions. So these aren't things that people need to do. They don't have that power, but they can sort of set out recommendations. And these are those that they make. Prescriptions guidance should encourage GPs to offer people over-the-counter medications on prescription based on socioeconomic grounds. I mean, shall we just talk about that, Gandhi? What do you think
about
that
one, actually, because that's probably the one that's
we'll end on that one.
Yeah.
We'll end on that. It's the most controversial for us,
Yes.
I think. They're talking about a review of supporting people in terms of their travel and reimbursing people for journeys to and from appointments to GPs, dentists, hospitals. Use of free phone numbers for NHS services. That's interesting. I mean, our practice number isn't a free phone number. It's a local rate number. There was a time, wasn't there, where people used to use these sort of 0845 numbers that had quite high costs in general practice and in services, and that was done away with. And they're talking about introducing free phone numbers. And talking about changes to the benefit system around the length of statutory sick pay and so forth. And then interesting, just given that we've also recently done an episode on digital health inequalities, which I'm sure will be linked to somewhere. I'm not quite sure in what order the episodes are going out actually at this stage. So it may or may not have already landed. But they're talking about access to broadband, and I think that'll be due to that question they asked about people struggling with the cost of accessing things, and actually broadband and internet is part of the cost of accessing some services, or at least in some of the ways they're encouraged to do so. So they're talking about support with broadband cost, essentially. Do you want to double back to prescriptions then, Gandhi? Because I've been dying to know your thoughts on this one.
So I think it's a challenging one because it's a double-edged sword. And why do I say that? Well, there are definitely patients out there that struggle to afford their healthcare, and by not having their medications, that can impact their journey, their health, and obviously the impact that has on the wider system. For example, if that person was a carer for another individual and they can't then be a carer because they're feeling unwell and they can't get access to medications, that's clearly an issue. Does not having access to those medications impact their health further? So I've had situations, for example, where patients haven't paid for their inhalers because they can't afford them. And actually then that leads to a hospital admission, which is considerably more expensive to the system than the cost of that individual inhaler, for example. Yeah. But, and the bit I don't know from the HealthWatch analysis of this, has that also factored in the cost of what they're suggesting to the system itself? And why do I say that? Well, like you mentioned, if you were to take a key example, a patient attending the practice asking for a prescription for paracetamol for a self-limiting condition that has temporarily made them feel really unwell, but because then they don't want to, or they can't afford the cost of that paracetamol, they've used a GP appointment. Now, GP appointments are free at the point of access, but it still has a cost to the system. The process of going to the pharmacy to then have that prescription processed has a cost to the system. And that whole journey is approximately £30 to £50 minimum to the system. So it has a cost. And how does that cost factor into those other aspects of things? And the other thing, by going to the practice to access that, as clinicians, we still have to evaluate the issue. We have to process that in terms of their other health problems. Is that medication safe for them to be prescribed appropriately, and what dosage? All those things factor into it. So it's using clinician time that is then not available for somebody else, because the reality is we are in a system which has capacity challenges, has demand challenges. So it's then taking up those resources for something that could be done through self-limiting, but for a proportion of people, they can't afford it. It's a really challenging thing. And then the obvious question then comes, where on that scale of deprivation do you put the line that says you can, you can't? That's really problematic. And for me, that's the biggest issue, because that if that's delegated down to the clinicians to make those decisions, everybody will make a different decision in a different situation with the same patient. And therefore it becomes really complicated, and you introduce bias, you introduce, conflict, you introduce problems. It's just so, ugh. It's in some ways it's quite intimidating, to be honest, to consider it.
Yeah, I agree with everything you've said, Gandhi. You've outlined particularly that kind of uh, medical economic, issue of, is this the most impactful use of healthcare resources and time, and actually would there be some negative consequences of actually going with this in terms of other people not receiving the care that can only be delivered by their GP practice,
Mhm.
because other people are using it for care that they can get elsewhere. So I think that's really, really astute and really, really important. I suppose the further points I would make is, they use the word guidance should encourage, and there's something about reducing variability here, I think, for me, because even within the practice, our GPs will have slightly different attitudes to this.
Mhm.
And, there are some GPs who are very hardline and they say, no, I will not prescribe you something that's available over the counter. And there are some GPs in some circumstances, who will do it. And we sometimes have conversations about when we do it and when we don't. And in the absence of, guidance, it's left down to individual GPs. So actually, there might be some people at some practices with some doctors who get a different experience and outcome to other people, other GPs, other doctors. And,
Mhm.
and maybe we accept that that's just part of the system, or maybe that's wrong, and represents a bit of a
Mhm.
postcode lottery. And I can see how, guidance might help with that, even if the guidance is never do it, which it sort of has been leaning towards in the past few years. The other side of this is, and I'm Gandhi, Philip, let my wheels turn for a second. I had something important to say, but tell me something on your mind while my wheels turn.
Well, I think the other aspect, so we talked about the transport aspect. So
Mm,
although we focus on the prescription one, I think also bearing in mind, it does mention about access to GP practices and other healthcare appointments through support for transport costs. Now, it's important to note there is something called the Health Travel Cost Scheme that allows certain patients to have support when it comes to their health transport costs. It's fairly limited. So GP practices are not included in that. It's mainly around hospital-based appointments, and it has to be at a separate time of when they've been referred. So say, for example, I wanted a patient, they needed help getting to that appointment. My understanding of the system is they can't actually be referred for support through the scheme and to their appointment at the same time. It has to be a pre-existing issue for them to have support for the costs, and then it's reimbursement as well, as my understanding as well. I'm not au fait with it, and that's why the recommendation suggests some changes. Interestingly, how do you balance the cost of paying for that appointment? And more importantly, who does it? Because if that then defaults to the practices having to process all that administration around supports for cost to appointments, it gets really complicated then. And it's workload we absolutely don't want to be doing, because that's going to take away us from patient care even more so. And I can guarantee you we're not going to get any funding to support that workload. So then that is a challenge. But it is a recognizable issue. I've had certain patients where I've said to them, you need to go to hospital. I don't have the money to go to hospital. Well, they're not appropriate for an ambulance, because that's really more cost to everybody and system, and impact on somebody potentially not getting an ambulance when they need it. So what do? You're a bit stuck then, aren't you?
it's
It's an
we
issue
just
that we need to be aware of.
Yeah, which I think speaks to an issue. Well, or I think where HealthWatch might be coming from with this guidance is, yeah, they're not in a position to dictate policy. I think part of what they might be doing here is creating some waves, and
Yeah.
starting some discussions around points that they know will be controversial, to make a point about the cost of living crisis, and make the system and everybody within it think. There are all sorts of wider system impacts of what they're suggesting, in particular the GP, prescribing over the counter medicines, for example. And I don't think they're necessarily ignorant of those, but I think they're just choosing to make a point to
Mhm.
the system and make people stand up and think, to give some impact to their research. I think that's where they're coming from. The other thing that I was going to say about prescriptions was, um, just highlighting that there have been schemes to help with this in the
Yeah.
past, such as what locally was called Pharmacy First, which enabled people in receipt of benefit and had other qualifying circumstances to go to their pharmacy and to get simple remedies like hay fever treatment, amongst other things, free of charge. If they would be eligible for a free prescription, they were eligible to get that over-the-counter medicine free without a prescription, and that was specifically put in place to prevent and mitigate this issue of people going to their GP practices using appointment time to actually ask for over-the-counter medicines to be prescribed, so that they could avoid, or so they didn't have to pay for them. It's not about avoidance; it's about their ability, to pay within their means, so they didn't have to pay for them and they could still access them. And that's been taken away, recently within Nottingham. I'm sure it's gone in a lot of other places. So it just feels like we're moving backwards. And I think we need to be mindful when the system is making these decisions about the impact on both health inequalities and the suffering of people, at risk in these low socioeconomic classes or circumstances, and also the costs that these then have back on the system, which might exceed the cost of the original scheme in the first place. So I think these are all important things to consider. But yeah, I think HealthWatch we're making waves potentially.
It's a useful talking point, isn't it, Andy? And I think, the other thing to reflect on, you talked about that a lot of the pharmacy first schemes, a lot of that was driven by various regional ICB and CCG decisions to cancel those because of the creation of the CPCS scheme, so the community pharmacy consultation scheme that was driven through from networks and stuff by government funding. The really interesting part of that whole scheme, though, was that although it supported the consultations to pharmacies instead of general practice to try and help the patient journeys and also tackle demand and stuff, the problem was the patient then still had to pay for the prescription. So for those areas of deprivation where patients would not normally pay for those prescriptions, then it became an even bigger problem, because actually all they ended up doing was just going back to the GP practice to get that prescription that they were now told they needed to have as well. So counterproductive, definitely feeds into this discussion that HealthWatch, I think, are trying to proliferate and stuff, and absolutely feeds into that concept of health inequalities and various other aspects of healthcare that really do need addressing, because it's a growing problem that we are facing, seeing and experiencing, both from practice perspectives, but absolutely from that patient experience point of view.
Absolutely. So I guess that brings us to the end of the report. We've done a number of other videos and have a number of other resources focused around inequalities and these issues, which I'd encourage people to check out. I guess people can walk away with that question in their head as as they go back to practice the next day. Will they be choosing to prescribe over-the-counter medicines or not?
Maybe we're sharing this video with your teams, particularly within your networks, particularly if you're looking at your health inequality plans within your network and that kind of stuff. And also, what does that mean for your practice discussions? What does that mean for your local area and stuff? Additionally, if you wanted more information on the digital aspects of stuff, well, as Andy mentioned, we covered this in a separate episode that's coming up right here that you can have a look at, that talks about digital inclusion, digital literacy, and other aspects and stuff, and exclusion, obviously. And as always, we'll be here to tech enhance your primary care and learning. And we'll catch you in the next episode.